they live, no matter what zip code they come from, no matter what part of our state they're from, that they will live to reach their first birthday, live to see their first birthday. We are also seeing another troubling statistic here in Ohio, which is a rise in maternal mortality and pregnancy-associated deaths. According to the Department of Health, the proportion of deaths that occurred among Black women, 34%, far exceeded their representation among the population of women who were giving birth. I'm sure many of you are aware of these numbers and have seen the troubling statistics and the complications from women who died from pregnancy complications. But according to Ohio Department of Health's 2019 report, from 2008 to 2016, the proportion of deaths that occurred among Black women far exceeded, again, their representation of the population of women giving birth in Ohio. We've also, around the country, we've heard stories such as the Serena Williams story. Serena Williams had the access to the best healthcare, but she still suffered disproportionately high complications. And we know that women in the United States, that Black women are more likely to have complications during childbirth, no matter their economic background. And this brings us then to the need to address these racial inequalities and inequities in our healthcare system and to ensure equal access to healthcare services. The Commission on Infant Mortality was created in 2014 with the goal of improving Ohio's infant mortality rate to help more Ohio babies celebrate their first birthdays. We had legislation passed back in the 131st General Assembly, Senate Bill 332, which was introduced by our colleagues then Shannon Jones and Charlita Tavares, which resulted from the initial recommendations made by the Commission. This bill was signed into law in December of 2016, and we've now had time to assess what else needs to be done because it is time to push for new legislation that can better outcomes and address the infant mortality crisis that is still facing us. We have seen several proposals, some of which include postnatal Medicaid coverage up to 12 months, specifying that Medicaid covered doula care and lactation consultants, expanding the PAMR board responsibilities for better data collection, ensuring continuing healthcare education for our birthing professionals, and recognizing that racism is a public health crisis. With that, we have speakers today to address some of these concerns, and we're really excited to engage our community partners in hopes to achieve better outcomes. Paramount in these are involving community support, home visiting, and the use of community health workers. Today, the Children's Caucus is fortunate to be joined by Dorian Wingard and Jessica Roach from Root, Restoring Our Own Through Transformation. We are also joined by Kristen Farmer, Birthing Beautiful Communities. And also the third presenter this afternoon will be Reem Ali from the Health Policy Institute of Ohio. First, we will hear from Dorian and Jessica about the work that Root does in the community and the challenges that they see in that effort. They will be followed by Kristen, who will share with us the information on birthing beautiful communities and give context to the challenges that Black women face while pregnant and postpartum in maintaining the health and well-being of themselves and their infants. And finally, we will hear from Reem about data and research on the factors that contribute to poor maternal and infant health in the state of Ohio, focusing on addressing institutional racism and inequitable community conditions and the social determinants of health. With that, thank you all so much for being here. I look forward to our discussion. I'm going to turn it over to Jessica.
Well, thank you so much for having us. We appreciate the time. Again, my name is Jessica Roach, and this is my partner, Dorian Wingard, and together we are Restoring Our Own Through Transformation. Today, we're going to take a little bit of time to not only discuss the work that we do, but also to give a little bit of the context and some information that we present to our other healthcare providers across the country in regards to the roles of Black community-based organizations and some of the historical content as well. Next slide.
So, as far as Root is concerned, I mean, this is going to be our organizational overview of Root. And so we are an organization of collective of concerned Black families, community members, and advocates. And we're dedicated to decreasing the Black maternal and infant mortality issues that were discussed at the introduction of this particular meeting. Our mission is specifically to comprehensively restore the collective well-being of our communities through collaboration, resource allocation, research, which is big for us, re-empowerment, and all of this is done toward the end of meeting the needs of the Black families that we serve. Next slide, please. Our impact statement obviously goes hand in hand with our mission statement. And for us, impact is measured in a way that is comprehensive and not segregated to a lot of the perspectives that typically permeate this discussion. So for us, our service model is not inclusive only of direct services, but it's also inclusive of the public policy advocacy and education that is happening here today. We'd like to go beyond those surface level risk factors that impact the folks that we're talking about and actually breed the health inequities that we're looking to address. Our focus and our perspective is that of structural and institutional, a structural institutional lens that we view the social determinants through, because without addressing those structures and those institutions, the symptoms of the issue just continue to permeate themselves, just looking different in different decades, but they're the same thing. Our intent is to work collaboratively with those folks, those organizations, those individuals that are aligned with our mission as well. Next slide, please. This slide is just a very quick drive-by on a portion of our senior leadership team. Obviously, Jessica and myself are here. Ms. Danielle Jackson is our intake coordinator. Destiny Benson and Laura Gourier act as our clinical coordinators and our home visiting coordinators respectively. Next slide, please. These next couple of slides are just a sample, a snapshot of the collaborative partners that we work with around the country. More notably is Common Sense Childbirth down in Florida and then National Birth Equity Collaborative. We're also working with the National March of Dimes on their policy task force. We just finished that call before this call, and the Black Mamas Matter Alliance. And what's important here is that we call out the Merck for Mothers Safer Childbirth Cities relationship that we have. We were designated a safer childbirth city through the Merck for Mothers program back as a 2019, I'm sorry, which we were one of 10 in the country in that inaugural group. And we've been working diligently to execute those goals and objectives since that time. Next slide, please. Again, another list of folks we work with, including the Black Maternal Health Caucus as well. So we like to anchor our conversations into the reality that without addressing and disrupting and dismantling those structural institutional determinants, we're not going to be able to really make any progress here. If we're not doing it from this perspective, we're just going to be spinning our wheels. Next slide, please.
And specifically when you're addressing aspects of Black family health, Black maternal and infant mortality and morbidity, which is the topic of which has become a very popular topic of conversation, you have to make sure that you're having the conversation in context of understanding how it is that our historical experience and current life experience have impacted us throughout all of the life domains. Next slide. We often have the conversation in regards to the web of causation and the social determinants, and that's a conversation that you'll hear most often throughout public health and through clinical aspects in regards to us as a people when we're talking about social determinants that impact us, like food stability, education, income, neighborhood demographics, access to care and housing, which is a big topic of conversation. But what we don't often do is talk about how it is that these social determinants were actually created. That gets back to more of our structure and how it is that we conduct our work from the basis of the structural determinants that have actually created the consequences of the social determinants. Next slide. And again, just as a brief, so that for the folks here, understanding that we can't go into what we typically do as far as our education component for healthcare providers and other policy and legislation that we've done on a national level. This is just one example of how it is that you can tie some of the issues that we see today within Black communities based upon policy that has been created. As in particular, if you're looking at the Shepherd-Towner Act, which was something that was created in order to address, at the time, infant mortality specifically, and more directed towards rural white women. It was also what led to helping create federal aid for the Maternal Child Health Bureau. However, what it ended up doing was actually creating rules, regulations for training and licensure that not only was inaccessible to Black women, but made Black women who were already practicing as midwives essentially become illegal. So we had a complete disruption of an active profession that had been passed on from generation to generation that we cared for our own communities, and that was basically destroyed. Next slide. And so for going back to where we were talking about the web of causation for the social determinants, this is the theoretical framework that has been developed by us for Root. It was most recently published in the Journal for Women's Health. This is in regards to what those connectivities are. So for us, knowing that and how it is that we address our population and our communities, we're very clear about the fact that you can't have the conversations about rates of incarceration, about access to care, about housing, without actually having the conversations about slavery, development of the 13th Amendment, Jim Crow era, the GI Bill, and redlining, which still impacts the availability for loan origination to this day through FHA and conventional loans through the banks. Next slide. Go ahead.
So Root overall, as a community-based organization, as a snapshot, these are the services that we provide. So most notably and most recognizable are the full spectrum perinatal support doula services that drive the direct interaction with the families that we serve. And ironically, we have a bill potentially pending here in the state of Ohio that folk on this call are aware of, that is looking to provide a certification for doulas and provide that Medicaid reimbursement for the services. We're also a healthcare training provider for healthcare professionals. We've done this all over the country, as far as University of California, San Francisco, back to the East Coast, and so it's something that we're very proud of, and we're anchored in it because it's needed at all levels of healthcare. We also provide consultation to other community-based organizations. We like to make sure that we are included in these conversations at the federal, state, and local level as subject matter experts, particularly on policy as it relates to this with Black families. Jessica mentioned the research and the social injustice and health equity perspective for us. We're very clear that implicit bias and anti-racism training, it's good, but we have to be specific and drill down with that. We're specifically focusing on anti-Black racism training and activism, because we understand that race-neutral solutions don't deal with race-specific issues. And so for us, we want to make sure that we're very clear on the health equity lens that we're using. Next slide, please.
So just to give you a little bit of background too about our perinatal support doulas, and I think it's really important to make those distinctions, especially because the conversation in regards to doulas is so popular right now, but not all doulas are the same. And looking forward to hearing from our colleague from Birthing Beautiful Communities as well, who can attest to some of the differences and how it is that our doulas specifically are trained, our perinatal support persons are trained. We are full spectrum perinatal support. Our perinatal support doulas can also provide breastfeeding education and lactation support. We do have currently 6 certified lactation consultants, and all of our staff is trained in very same or similar ways. They are well-versed in health information and equity advocacy. We are family-centered and informed decision support. And we also do home visiting provider. I think it's really important to stop here at this point and also note that our training in and of itself isn't just a 20-hour over the weekend and going out and then starting to provide services. Our training consists of almost 64 hours in seat, and then there is an extended apprenticeship period that all of our perinatal support doulas have to go through, which also includes being able to learn things like basic nursing assessment, clinical and lab interpretation, being able to provide nutritional support, just being able to do the full spectrum of care from a clinical, socio-psychological perspective, as well as the legal and ethical, so that we can make sure that our perinatal support doulas are able to provide medically accurate information so that our families can make a better informed decision. Next slide.
These are a couple of quotes that we like to utilize to guide our work, and we leave our audiences with. Jessica, drives home the point that if we don't acknowledge some of these things, we're not going to move the needle at all. And I've already mentioned the reference made here in this one with regard to race neutral solutions. We have to be responsible for our own knowledge and growth in this area, and being sure not to silo the conversations in a way that just perpetuate the same type of segregationist policies that have happened in the past. Next slide, please. This slide really is just a highlight piece, and folks can go back and take a look at this on their own time. It just kind of chronicles the timeline of us as an organization. We started in Jessica's kitchen back in 2017, and now we're talking to you all now. These, again, are some of the milestones with regard to that. Next slide, please.
This is just giving you a snapshot of, this was our root COVID-19 protocol and the impact. And this was something we created this almost immediately when it became apparent that this was going to ultimately become a pandemic. We started instituting before there was even a lockdown here in the state, some of the protocol that we had for our staff and our clients. We have always done well with being able to, since the beginning of our organization, with teaching infection control, universal precautions across the board. We just simply amplified that with our staff, made sure that all of our client family engagements went to virtual. And we were able to do that very, very quickly because we already had a virtual component that was incorporated into our protocol, because we know very well that our families, we've got to meet our families where they are. And so ultimately, sometimes it is better to be able to meet them at work for lunch, or be able to get them on a telehealth call. And so we were doing that prior to COVID-19. So we just expanded that service. We made sure that all of our staff was equipped with pandemic training and appropriate PPE. And then you can see along here some of the other things that came up. One of the biggest issues that I think is that we're just now seeing that we're starting to come out of was some of the adverse impact. And the adverse impact that we were seeing for our population was that there was an increase in erroneous health information. There was a significant increase in premature scheduled inductions and increases in forced and coerced surgical births. A lot of these were across the hospital systems. A lot of this was coming out of the or born out of trying to state that it was a means of being able to have better infection control, but wasn't really discussing what some of the ultimate longer term impact could be, or some of the risks that are associated with premature scheduled inductions, or with non-essential cesarean sections. Next slide, please.
And we'd like to end with this slide. I mean, the photo you're seeing was back in, I think it was 2017. And it's a group of parents, families, their children. I think the majority of the children you see here are root babies and root families. And also to the left, our left there, is a NPR StoryCorps story that our interview that we did with NPR back in 2019, that pretty much chronicles our origin story and what our value proposition is with regard to the work. So you can feel free to take a listen to that at your leisure. And so we're done and are here for any questions that may come up toward the end, after the end, the next presentation, I guess.
Thank you very much. We'll move on to Kristen Farmer, and we'll do questions at the end. Thank you.
Good afternoon. Thank you, Jessica and Dorian, for that wonderful overview. I'm Kristen. I'm the CEO and founder of Birth and Beautiful Communities. We got our start around 2015. Is when I formally brought together a group of African-American women, doulas, at the time, where I was looking to train more African-American women in the Cleveland area, because at the time I thought that I was the only Black doula in Cleveland because I couldn't find any other doulas. And I wanted to be able to provide our community with the services that a doula provides. So we spent up to 80 weeks with the clients from very early pregnancy. We attend a labor and delivery, and we're with them until the baby is a year old. In that time, we do classes. We have 2 to 3 classes per week. We take them through what we call our perinatal support pipeline, which is basically from intake all the way to the baby's first year. I developed something called a social risk assessment that puts the category of 4 categories, ranging from fawn to cub to kitten. And we assess based off of the circumstances that the mother has gone through in her life from a social standpoint, because infant mortality is primarily a social issue. So we look at the mother's history, and then that helps us to determine the number of hours that we should spend with the mother, and that determines the classes or the type of classes that she needs to take while she's with us, and whatever other supportive services we feel that we need to provide her with within that time. We are located in Cleveland. We have a second office in Akron. As of 2019, the last official evaluation that we had done, we have a 99.2% infant survival rate. Things had got a little crazy and slowed down through COVID, as you could imagine, because then we couldn't really go into the hospitals how we wanted to. But now we are allowed to come back into the hospital. So we're really starting to get our sort of programming back to a degree where we want it. We have been online for the last year. So we are hoping to go back into person pretty soon. So I am charged with talking about, I wrote it down here, challenges Black women face while pregnant in the postpartum period. And I think that to Jessica and Dorian's point, as they brought up sort of the historic inequities, it is important to sort of take a look into those historic inequities. But a lot of the stress that the African-American mothers feel, which prematurity is the driving factor in infant death. In 2019, Birth and Beautiful Communities and Kent State University did a cortisol study, which to measure the stress levels, because what I wanted to see is if African-American women were experiencing stress at a higher level than non-African-American women at the same period of time of gestation. The short answer is yes. But what we did in this study was we took hair samples from hair from the back of the neck here from the moms. And then we actually measured it over a 3-month period of time to measure the cortisol levels. And so what we found in that was that, yes, African-American women do have a higher stress level or higher cortisol levels during the gestation period. And it's on 2 different spectrums. So you have the group of women who are experiencing these higher incidence of cortisol, and then you have women who are experiencing a very low incident of cortisol. But the low incidence of cortisol just says that the mother has built up resilience because she is anxious, she's depressed. And so all of these sort of clinical factors that go into how we internalize our stress and what it does to our body, suppressing our immune systems and so forth and so on, which makes us more susceptible to, of course, to disease, but then also as well to prematurity. And one of the big factors that I, often say is that, unfortunately, in this country, African-American people have had to be dependent upon systems that don't work for us. And so there's a lot of stress that's associated with trying to force yourself to fit in or be a part of a system that was never designed for you in the first place. So I'm a fan of African-American or Black people building our own systems and building our own infrastructures. And Birth and Beautiful Communities is what that is. So, we'll be breaking ground on a birthing center. We did get funded. Shout out to the Gun Foundation, who funded us $1 million to build a freestanding birthing center in the state of Ohio that we plan to break ground on this fall. And I think that sort of model should be taken into other aspects as well too, because for example, one of the things that we don't talk about when we are talking about redlining, for example, is that there were hardly any Black banks at the time either. So if we had more Black banks, more Black infrastructure, then more Black people probably would have had more loans, right? Because I think that we always take out this cultural aspect of it when we're talking about systemic racism, which I view in a different way. I think that we definitely have a lack of infrastructure that supports the African-American community, right? And so I think that if we are talking about legislation, there has to be somewhat of an emphasis on the fact that some of these infrastructures have to be built up, and they can be and should be exclusively for African Americans, because we are talking about a 400-year of historical inequities, right? And so that wouldn't be unjust or unfair, to be able to lend support in those areas of where we need that infrastructure built. Economic wise, that could be in banking and finances. Health wise, I just used the birthing center as an example. But these are the big issues that then lead to sort of being in this hotbed of stress when you are constantly trying to be a part of systems and infrastructures that are not welcoming to you or just are not designed for you in the first place. So a part of our work at Birthing Beautiful Communities is creating those spaces. And a part of my work, which is a part of this, but a bit separate because I'm working on this project right now with Cleveland State University, where we are developing 2 grants. We were funded by the state of Ohio and Third Frontier to develop 2 apps. One would be digitizing this model that I just talked about with the perinatal support pipeline, with the social risk assessment. So putting it into an app coupled with a bunch of different functionalities for the mother. There's also a social risk assessment on there for the father as well, because when we are having these conversations, we tend to leave the dad out of this, and we don't take into account the amount of stress that the African-American male is under as well too. And so going back a little bit, when we did do this study with Kent State University, we did a qualitative study. What came out of that as well is that 3 things that the women highlighted that they were experiencing: isolation, financial stress, and partner stress, right? And so I had created this chart some time ago that sort of outlines paternal stress and how paternal stress impacts maternal stress. But the biggest thing with the fathers, because we did a pilot on this and we have data from that showed that the fathers lacked sufficient income. The men that we had coming through our program reported having less than $10,000 annually in income. Education was also a big factor as well. So then the question becomes, if we want to support the mothers, then how are we supporting the fathers so that they're able to support the mothers, right? And so mass incarceration is a big part of that, because with mass incarceration, what that did was take a whole lot of African-American men out of the community. And so when that happens, then the mother is then left to work 2 or 3 jobs or be able to support or try to support her children in the best way that she can. And some years ago, I had did this presentation that showed how mass incarceration impacted the lack of breastfeeding within the African-American community. But as you can imagine, if a mother has to work all of these jobs and she has to do all of these things, then that lowers her chances of being able to continuously breastfeed, not to mention stress. The cortisol levels are high. And so that also suppresses the milk flow. So we think of these things as very separate, but they're interrelated. And they're so correlated. You can't talk about one without talking about the other. It's how do you make that sort of connection? So back to this Cleveland State study, we are now doing the developing the app that will digitize our model. But then we are also developing a second app too that is specific for the economic infrastructure in African-American communities. So this is helping the fathers to either become entrepreneurs, providing a service, or we are assisting them in finding employment from service providers on this platform. And again, this all leads back to poor birth outcomes. So we are focusing on this. We know that it's a wealth gap, and we know that that we have health disparities and we have wealth disparities, but we talk about them as if they are not related, and it's not true, right? That because we have a lack of infrastructure within the African-American community, as soon as we make money, it leaves our community, right? It doesn't circulate in our community the same way it circulates in the Asian community or in a Jewish community or so forth, because we don't have infrastructures to be able to accept those dollars, right? And so if we have that in place, then there is a way for us to mitigate the stressors that the mothers are facing through finances, right? And also that partner stress. Now, the services that we provide at BBC really take care of that isolation piece that the mother is facing. So moving forward, a part of the legislation that we have also been speaking about is around midwifery, right? And midwives, because we don't have enough midwives in the state of Ohio. And so with this birthing center that BBC is building coming online, midwifery is more important to our cause more than ever. And so we do need some more regulation or pathways so that we can train more women to become midwives. And we can particularly train more African-American women to become midwives as well in the community, because we should be able to have that choice. The results are sort of shared already. We've seen well over 700 families to date, and that number is actually closer to 800 or even more at this point. We have trained more than 100 women as either doulas, birth, postpartum, or as perinatal support professionals. Infant survival rate, 99.2%. Our breastfeeding rate has been consistently around 85%. And for African-American women, that's really high, because here in the state of Ohio, our breastfeeding rate is around 64%. Our C-section rate is much lower. Our prematurity rate is much lower. And we have an evaluation that I can share with this group and this panel for those who are interested in seeing so far what our outcomes have been. Thank you.
Kristen, thank you so much. We appreciate that. We'll take questions again at the end. And so our next presenter is Reem Ali. She's the Vice President of the Health Policy Institute of Ohio. Thank you.
Good afternoon. Thank you for the opportunity to present this afternoon. I hope to build on and reinforce the important information that Jessica, Dorian, and Kristen have shared so far. For those of you who are not familiar with the Health Policy Institute of Ohio, our mission is to provide the independent and nonpartisan analysis needed to create evidence-informed state health policy. I'll be focusing my presentation on racial disparities in infant mortality in our state, and then the factors that contribute to those disparities. Next slide. Compared to other states, Ohio ranked 42nd on infant mortality based on 2018 data. Next slide. In addition to Ohio ranking poorly relative to other states on infant mortality, Black Ohioans, as you've heard, experience very troubling racial disparities. And I'll be sharing findings from a fact sheet focused on eliminating racial disparities in infant mortality that the Health Policy Institute of Ohio released just a few weeks ago. Next slide. As you heard Senator Kunze share earlier, in 2019, the most recent year for which we have data for Ohio, Black infants were dying at nearly 3 times the rate of white infants. Even more concerning, over the past decade, we have seen these disparities widen, with the Black and white infant mortality disparity increasing by 26% from 2009 to 2019. For over a decade, Ohio's leaders have acted to address these disparities through advisory committees, collaborative efforts, investments, legislation, policy change, but these disparities have persisted. And I'll be going over the drivers of these racial disparities. In order for us to be able to identify how to move forward, we really need to understand what can drive change. Next slide. As you've heard from the presenters today, the research evidence is very clear that racism is a primary driver of racial disparities in infant mortality. Disparities persist even when taking factors such as income and education into account. In 2017 and 2018, the Black-white disparity in infant mortality for Ohioans with bachelor's degrees or more was 2.6, which is still greater than the Black-white disparity in infant mortality for Ohioans with high school diplomas or less education, which is at 1.9. What that tells us is even when you factor in education, these disparities remain. And as you can see on this slide here, racism manifests both directly and indirectly to impact maternal and infant health outcomes. For example, as you've heard about this afternoon, through toxic stress resulting from experiencing racism, which is linked to preterm birth and low-weight births, which are both leading causes of infant mortality. Next slide. When we think about the types of interventions that can be taken to improve health, it is important to understand that only 20% of our health is attributed to clinical care. 30% is attributed to health behaviors, and 50% is attributed to community conditions, such as housing, transportation, and employment. Next slide. In addition to the direct impacts of racism, infant mortality disparities are fueled by racist systems, policies, and practices that disadvantage communities of color, resulting in inequities across these community conditions. Next slide. So just as an example, see the data here that Black children in our state are 2.9 times more likely to live in poverty than white children. And Black adults are 2.5 times more likely to live in poverty compared to white adults. Families that are living in low-income households have difficulty affording basic needs that impact maternal and infant health outcomes. So that would mean things like accessing quality, safe, stable housing, healthy foods, all important factors when thinking about delivering a healthy baby and having a healthy pregnancy and healthy mom. Next slide. When talking about maternal and infant health, we often focus quite a bit on just the period of pregnancy. However, the health of mothers before pregnancy can have even greater impacts on racial disparities in birth outcomes than the period of time an expectant mother is pregnant. And prenatal care, case management, care coordination during pregnancy is extremely important, but sometimes it can be too little too late in addressing the root causes of racial disparities. So for example, traumatic events experienced early in life, such as adverse childhood experiences or ACEs, can have significant impacts on physical and mental health later in adulthood. And in Ohio, what we see, unfortunately, in the data is that Black communities are more likely to experience exposure to multiple ACEs. Next slide. Given all of this, these are 3 policy approaches that can be taken to drive change and eliminate racial disparities. First, we can help families build resilience in the face of trauma, toxic stress, and the cumulative impact of racism that exists and persists across generations. This includes dismantling racist policies and practices, as you heard Jessica and Dorian talk about, and rebuilding the trust of Black communities. Second, it is important to take the approach of improving health across the life course and not just during pregnancy. It's critical that any programs and policies that are put in place are tailored and that resources are allocated to meet the needs of Black families specifically. And to echo what Kristen said, it is going to take significant investment in Black communities to create the solutions and close the gaps that we see in these outcomes. And then finally, it will be important to maintain improvements in access to clinical care while also advancing meaningful policy changes to improve community conditions. While racism is a primary driver of these disparities, the inequities that we see fueled by racist policies and practices across housing, across education, across employment must also be addressed. And I just want to share that there have been many efforts to bring together stakeholders from across the state to prioritize evidence-informed strategies to address the key drivers of infant mortality. And you see here on your slide just a few of the reports that HPIO has been involved with. There are reports that other organizations have put out as well, and many of the recommendations in these reports have yet to be implemented. And the bottom line here really is that these disparities are not inevitable, and there are concrete evidence-informed steps that Ohio can take to both improve and eliminate these disparities over time. Happy to stop here, and I know we're going to go ahead and take questions.
Well, great. Thank you so much, Reem, for this presentation to really cap the two presentations that came before. Jessica, Dorian, Kristen, really appreciate both your experiences as well as the data and the information that you've presented to this panel. I do want to open it up to some of our legislators, and I see we've got quite a few. We also have some of the aides on as well, but I know we've got some legislators. If you want to ask a question, just take yourself off of mute and ask the question. And while you think of those in the last few minutes, I did want to throw out, one of the things that we have been talking about in the Children's Caucus, we've prioritized some policies going into the budget. And one that directly relates to the topic that we're talking about today is around, how can we better utilize the benefits of Medicaid, particularly when we know that more than half of all births in the state of Ohio are covered by Medicaid. Right now, women only get postpartum coverage for the 60 days after the birth. And there is very good evidence that actually extending that coverage from 60 days to 12 months of postpartum can have a very good impact in covering that in between pregnancy and that period of time when we know, as Reem noted, that we can have significant impacts on the health of the mom and also having healthier babies. So I'd love to hear, some of our panelists' thoughts on that and the importance of that postpartum period and extending the access to services and appropriate services during that postpartum period. And our panelists, you can just take yourself off of mute. Jessica.
We thought Kristen was going to go first. That's what we were waiting.
Nice point. Good point.
Go ahead.
So the question is specifically, what do we think about the expansion of Medicaid services to include a 12-month postpartum period? I mean, and the very simple basic answer would be yes. I mean, any opportunity that there is to be able to expand services, and also to be very clear, to have those postpartum services also include the very important role of the perinatal support persons and the perinatal support doulas, because not only do we need to expand coverage under Medicaid, but we need to expand the definition of what the perinatal care team actually is, and what are the multifaceted components that are necessary to be able to achieve the outcomes that you see that are coming from organizations like Root and BBC here in Ohio and other organizations that mirror ours across the country.
Kristen, did you want to add anything to that?
Just that's one thing that the United States does not do versus other developed countries. Other developed countries, already have a lot of that in place, where it's included in the leave, and there's even some countries that have payments for postpartum, families, or issue them support or will pay for a support person. So that's one of the many things that the United States does drastically different from other developed countries. So that would certainly be a value add to our state.
Just to add on to that, and to add in Kristen's line of answer, I think it's important to note, if it wasn't already mentioned, that the United States is the only industrialized country in the world that has an increasing rate of maternal and infant mortality at the rate that we do. In particular, we're the only country in the industrialized world that has an increasing rate of maternal mortality. Ours is similar to or worse than countries like Iran. So to put those things into perspective.
I just add to that, to put it in an even greater perspective, we're in the bottom quartile of states. So if the US is doing poorly on these issues, Ohio is at the bottom of the pack. I would just also add that, yes, that expansion of coverage is important, but again, it's also very important to ensure that that is tailored and targeted towards Black women, and making sure that those services are accessible and the providers are representative of the communities. Otherwise, we're just putting in place another policy that's likely not going to have the impact that we intend it to have.
Thank you all, and thank you for re-emphasizing the point too, not only to expand the coverage, but also making sure that we have those supports and those support professionals also reimbursed for their services, the doulas, our lactation consultants, our midwives, et cetera, that is an important component as well. And Reem, your point as well, that it fits the needs of our Black communities is also important. So I wanted to open it up if any of our other legislators, again, just take yourself off of mute, and I will try to find you and recognize you on the panel. Representative Lightbody, go ahead.
Thank you, Representative Russo. Reem, I wanted to ask you just for a little bit of help. I was squinting hard at your slide about the reports that have been released. I'm an educator by background and I'm still learning more about this particular area and trying very hard to support legislation and policy that would be advantageous to combat some of the issues that we've been hearing about today. Is there a way that you can help me find those reports more easily than zooming in on? I did take a screenshot of that particular slide and I think I could probably find them, but is there an easy way to find those reports? Because I'd certainly like to see what policy they recommend that we haven't started addressing.
Absolutely, Representative. I'm happy to. Oh, I think Allison's already popping some into the chat box, but I will pop the links into the chat box if she misses any, and then happy to follow up as well and just send those reports over.
Thank you very much.
You're welcome.
And I will emphasize that we're happy. We will send the links out to these and our follow-up. We always do a summary after these caucus meetings. So we will make sure everyone has the links directly in that email.
And before I turn the microphone over, let me just say thank you to all the presenters today. You've been very informative and helpful, and thank you for your passion and work in the areas, because this is not easy work and yet super important.
Thank you. Any other legislators?
Rep. Russo, while we're waiting for them to get their thoughts together, I think it makes sense also to point out that as we take a look at, from a state level, policy level, take a look at, I guess, right sizing our approach to perinatal support doula work and their reimbursements through Medicaid, that we take a look at not doing so in a way that creates more of the same that we've been seeing. What do I mean by that? Right now, the proposal is to place the Doula Advisory Board under the Board of Nursing, which would not be helpful. And so one of the things that we're continuing to talk through here on our side is how to navigate that in a way that creates a policy approach that will not continue to perpetuate the same types of inequities that we're already trying to battle against right now. And to try to force square pegs into round holes at this point won't be helpful. But what would be helpful is to continue the conversations about the innovative approaches that Kristen's mentioning, that we were talking about, based in the empowerment data that Reem presented in her presentation, so that we're able to hit a reset on how Black families are engaged, on how those experiences are created, and on how those birth outcomes can be improved. Should be improved.
Thank you, Dorian. That's I think a good and important point. And I've heard some discussion in that space before, but thank you for bringing that up again. You know, that brings another question. If no one else is going to ask the question, we hear a lot about doulas and the work that doulas do. And I think for many people, including many people on this call today, Can you help us demystify the profession a little bit and really talk about the role that doulas play, not only during the birth, but also, again, critically, that prenatal and postpartum period? Can you spend a little time just talking about doulas and the profession and how that works?
Yeah, so I want to first make the distinction that, so the profession of a doula is someone who you hire to attend your birth. You might see this person once or twice before you give birth. You might see them a little after you give birth. So I want to make the distinction that what BBC does and what Root does is far more extensive than that of a doula. Right. So, I know that we have sort of gotten on this wave of, okay, let's just, reimburse people who say that they're doulas, right? Because there isn't any sort of certification around, or I should say from a state or legislation point, not saying that there should be, but technically anybody can call themselves a doula, right? What BBC offers, what Root offers is extensive training, right? It's well beyond just, we might have a call or see you a couple times before the birth, and then we see you at the birth, and then we might do a follow-up after that, right? So that's generally what most people think of when you are referring to a doula, right? Which is the emotional and the support, and the emotional and social support. A doula is non-clinical. This person does not deliver babies. This person is there to help, to some degree, educate the family around their options and give them the options, lay out all of those options for them, right? So when we're talking about the perinatal support, doulas or professionals, then that's a lot more, again, extensive, right? So they are educated on breastfeeding, they're educated on, a lot of different things that could go wrong, or, and then what the options are. I know at BBC, we stay with the parents for 80 weeks for the purpose of it being just beyond birth. One of my very early clients before I started BBC, I can remember thinking what sort of motivated me to start BBC was that, okay, sure, I can go to her labor and delivery, but what about everything that's happened in her life before I came? You know what I mean? And then what else is going to occur after this baby is here? So there should be a distinction and even some provisions when we are using the term doula, because I definitely think that it's still kind of loosely used, and and not in conjunction or apart from the programs that are more extensive and the work that needs to happen, particularly for African American families.
And just to actually, Kristen did a great job of explaining it, and just to emphasize and maybe bring out even a bit more, I think that that's part of the reason why there is some of that where you're asking for us to demystify it, because there's definitely different levels of professionalism. I think about it from this perspective in this analogy, like in nursing, you have an LPN, you have an ADN, you have a bachelor's RN, you have an advanced practice nurse, you have a master's degree nurse, you have a PhD, a doctorate of nursing. There's different levels. We're saying and contending that that's very same and similar to what is happening within birth workers, as far as being a doula, being a birth doula, being a postpartum doula, being what we are, which is more of the full spectrum perinatal support doulas or perinatal support professionals. We're kind of more at that more advanced practice level. And I think it's really important to make that distinction that, one, while we're still a non-nursing profession, we do have a clinical background as far as our perinatal support doulas and perinatal support professionals are concerned, because we have that more advanced training and our own certification process that you have to go through in order to be able to take a look at the whole person, as well as the whole circumstances of life, again, as well as the experiences that have led up to pregnancy and led up to the birth. I think it's really important to note that birth doulas are very typically about supporting the birth. which is important, and that's what some families want. But in particular for us in our community, because of the intersection of all of the issues that we have to deal with, systemic institutional racism, issues with medical conditions that may more adversely impact us as a community versus others, again, still rising out of racism, we need to be able to have access to, and Medicaid needs to reimburse at an appropriate level, those of us that are acting in this perinatal support way that works very directly with the healthcare providers, works very directly with the hospital systems, in addition to our families, so that we can be sure that we can continue to provide the outcomes. Like BBC was talking about their outcomes. Our outcomes currently, we're at 0% maternal and infant mortality rate. We have less than 5% premature low birth weight. We have a less than 8% NICU rate for our babies. Our average stay is 4 days versus the national average, which is 14. Those are the things that need to be looked at, especially when you're talking about it from a cost benefit analysis. It's much less to pay us than it is to actually have children with, and to have to look at the heartbreak of having children that have long-term health issues when these things can be actually mitigated by professionals like ourselves. And it's extremely important to make sure that for Black communities, we get to have Black professionals that are working with us.
So thank you. That I think for me, that was extremely helpful to hear that. And again, we're at the top of the hour. I just want to say thank you to all of our panelists. This has been fantastic information. I know I've learned a lot on this, and I always do when I hear from you, Jessica, and Dorian and Kristen, and Reem as well. So thank you to all the offices who joined us, all the legislators, our colleagues who joined us to tackle this very important topic. And we look forward to having more in-depth conversation next month at our next Children's Caucus meeting. Thank you all.